I'm happy to introduce Sjoerd Stufkens, orthopedic surgeon from the Amsterdam UMC, focused on ankle, foot and ankle, and he will start the talk, and then I will continue.
And now for something completely different. Um, Jari and I will speak about tissue instead of people, but of course that's not true. Behind every injury and every tissue lesion, there's a patient. So please don't think that we're only looking at the tissue without looking at the patient in a biopsycho social context. But we will focus on the tissue, and the tissue will be cartilage. And cartilage is difficult. So how many of you, to make this a little bit interactive, how many of you have seen cartilage in real life? Yeah, that's like at least 70, 80%, which is good. Um, this is, of course, an ankle joint, and there's damaged cartilage. So this is a typical patient, and you have to ask yourself, well, what do we have? What can we do? Where's the pain coming from? What's the problem? Um, the thing with cartilage is there's some very old knowledge saying that when cartilage is destroyed, it cannot be recovered. And the question, of course, is why is that? What's the function of the cartilage? Well, it's a force transfer tissue. It's transferring enormous forces, multiple times the body weight over the joint from one bone to the other, and it's doing it without friction. There's almost no artificially made substance that can do what cartilage can do, frictionless motion transfer, and its ability to withstand hydrostatic pressurization, which makes it a awesome sort of tissue, but also a troublesome sort of tissue. When we speak of cartilage, articular cartilage, we speak of hyaline cartilage. Fibrocartilage is much tougher, like the menisci, for example, and then there's also elastic cartilage with elastic fibrils, but we speak about hyaline cartilage. So, what is that? It's glass-like. It's glassy, shiny cartilage with an extreme smooth surface, where the collagen fibers are bent in huge arcs, and it's making a sliding surface. Other constituents are chondrocytes, so that's the cellular component. And there's the extracellular matrix, which actually does all the work, consisting of the glycosaminoglycans, proteoglycans, a lot of water, not that much solids. And what was that with water? It's this brush-like polysaccharides which attract sodium, potassium, and the ions bring water along. We know that back from a long time ago. Other constituents, the hyaluronic acid, etc. So what do these cells do? They produce the extracellular matrix, they're immobilized, they do some development, repair, and maintenance of the matrix, but they have limited healing capacity, and they don't replicate very easily. It was long thought that they don't replicate at all, but they do, but they do it slowly, and they don't have contact with each other. So they're pretty lonely. A question for you is what do you think that the chondrocytes in the total volume of cartilage, what do they occupy? Can you just shout a number? What volume do the cells occupy in the total volume of cartilage? 1? Someone more? Less? Less? It's about more or less, yeah. Now it's about 1 to 5%, about 1.6%. So they're really lonely, and they have to synthesize a lot of volume of extracellular matrix by its own. You can say it's barely alive, cartilage, which makes it a unique sort of tissue. And the ECM does all the work. This have really unique properties in the permeability and viscoelasticity because of the low permeability. Um, it has a fresh, fast pressurization. You can think of hitting the water with your flat hand, and you feel that there's a lot of resistance. It's hard to push the water out of the ECM, and that's giving its unique pressure distributing properties. So the cells, they don't do much. The ECM does all the work, but the cells have to produce the ECM, and that's about sums up the problems we have with cartilage. So what was tested on the properties? The short-term deformation is interesting. In the years that the MRI became popular, they were able to start doing testing in 5.0, and they found that this primary function is not to absorb energy through deformation, it's just to distribute over the subchondral bone. So only a small fraction of this deformation, here they put like 150% of body weight on a knee joint and pushed it into an MRI scanner, and they saw that in the first minute only 3% of the cartilage thickness was changed, and even after 8 minutes only 9% of the cartilage thickness was altered. So there's not much deformation. Also, they have these kinds of experiments where they make people do knee bends, and to measure in the MRI after 50 or 100 knee bends how much the cartilage deforms, and it's not much. So it's about 2 to 3% of the thickness for normal activities, and maximum of about 6% with heavy exercise. So it's quite stable, and the water is not pushed out easily. What about the long-term effects? So does it deform? Yeah, here the fishbowl comes back into play. So about the long-term deformation, that we see a lot of inter-individual differences in cartilage thickness, but it's not thickened by exercise, for example. So you cannot strengthen your cartilage, making it thicker like you do your muscles with exercise. It has about the right thickness for everyone, and there's individual differences because of the genome, but you don't train your cartilage. There are studies that found that in high-end athletes, there probably is even more adaptation in the growth of bone near the joint. So the joint surfaces become larger instead of cartilage becoming thicker. And probably the limitation of cartilage to adapt to mechanical strain is part of the problem it has by not being able to repair. So how does the natural history of a cartilage injury then proceed? First of all, it's avascular and aneural. So a cartilage fissure is not painful. It's the inflammation reaction or the nerves in the bone that are stimulated that produce the pain. So initially there's no pain, and if it's quite a large structural damage, continued loading leads to further damage, and the damage sometimes is up to the subchondral bone. When the subchondral bone is reached, where that's the blood vessels are, then it leads to bleeding, and the bleeding start an inflammatory reaction with recruitment of mesenchymal stem cells. They go into the cartilage and they differentiate and they form new cartilage, but this is fibrocartilage. And the fibrocartilage is not as smooth as hyaline cartilage and not as stable. It degrades over time, and it's probably the pathway leading to osteoarthritis. Jari will get into this later on. So all of our tactics are then based on either stimulation of natural repair, where there's not that much natural repair and it takes a long time of the chondrocytes to heal. And for example, after a direct blow, in case of a fracture, there's apoptosis of the chondrocytes. Then those apoptotic chondrocytes don't repair at all. So the cartilage that's lost is probably lost forever, until there are deep lesions into the bone where you have recruitment of the stem cells. So the natural repair, it is still a hallmark of our surgical strategies. Then there are joint homeostasis therapies, because we know that cartilage degradation is mediated by inflammatory mediators, cytokines, interleukins, and you can think of inflammation reduction and removal of um, the bad signaling proteins. Then, of course, there are cell-based strategies by replacing chondrocytes. Stem cell therapy is upcoming. A lot of research is done after stem cells. Um, and there are surgical therapies in the corner of unloading and joint replacement, where, of course, joint replacement is suffering from its success. Uh, um, they're so successful that even people in younger ages, they receive joint replacement therapies. And I'm talking about knee and hip prosthesis, but also the other joints. So how about this natural repair stimulation? You probably all have heard of micro fracturing technique and the subchondral bone stimulation, where bad cartilage is removed. And with a probe or other instruments or a drill, holes are drilled into the bone to promote the healing, the blood clot formation, and the stem cell recruitment. It's really the gold standard since and even more so since arthroscopic therapies became available. However, though, this stimulates formation of fibrocartilage, and that probably degrades over time as well. So this is not a definitive solution. We're still looking for better treatments. For example, autologous chondrocyte transplantation, where a little membrane where the defect is created, cells are harvested, cultured, and reimplanted behind the membrane, or other techniques like this. Cell, scaffolds, many developments have been there. It looks nice, it looks good, although the results are not 100%. And a key element to this is probably that early treatment matters. And we here go back to the joint homeostasis. Probably after a while, there's an favorable environment, also with inflammatory mediators, and the reimplanted chondrocytes are lost again. How about other treatments, such as a replacement of an entire unit of bone and cartilage? Oats, for example. Well, the problem is also the harvesting site, where clinical studies show that harvesting from the knee and bringing it to the ankle can cause knee pain. So you have not treated your patient there, huh? Other cells or platelet-rich plasma therapies. Well, we know that in goats it's not working, and recently it has been shown that in patients it's not better than the placebo. Is it a dead end? I don't know. At least we know that here other factors also play major roles. Then there is the autologous conditioned serum, has been proven to do the same as a placebo. And then other big surgery, such as allograft transfer, since cartilage is barely alive anyway, you can harvest it from a deceased person and implant it in a live person. The bone cells will replace, and maybe the cartilage, but you mainly transfer the ECM. Looked promising initially, but coming with a lot of complications. Rejection and infection complications up to 42%. So here's neither a solution. So where do we stand? We know that cartilage is difficult. It's a difficult tissue. It's barely alive. We try to regenerate or to stimulate to regenerate, but it hasn't been 100% successful. The current repair tactics consist of many different strategies, where the surgery is suffering from maybe teamwork, trying a biological solution where psychosocial help is required, but also at a cellular and a biological level, there need to be more teamwork. And where's the future? I don't know if it's in other cells, other cell theories, or combinations. Probably it's in combinations and creating the entire environment for local therapies or cell therapies to be more successful. Going back to the homeostasis, how do we create the overall favorable environment? And I think that's where the holy grail is for cartilage lesions. Is this with the distraction therapy? Has been shown to be very promising in the knee joint. Look, here we see regeneration of cartilage on an MRI. The joint pain returns. Why is this? Because we know that cartilage requires loading in order to repair itself. We know for the ankle, for example, that it does not work. The joint becomes really stiff and it doesn't last for really long. So why does the knee work and the ankle does not work? We know that realignment surgery helps in creating a better environment, that asymmetric loading, peak pressures lead to cartilage degradation, and that realigning and distributing pressures, that's helpful. But also here, surgery is not the only option, and we need to combine our strengths to find future cartilage treatment solutions. Jari, from here you continue. Thanks.
Thank you. So, thank you, Sjoerd, for this introduction into the anatomy and also the physiology around cartilage. And as he mentioned and highlighted, it's all about the homeostasis. So, thinking back about that homeostasis, it's probably the same for our whole team. Everything needs to be aligned and everything needs to work together to go into future treatments and find the holy grail. So that's introducing a little bit on the team that we have. We have specific researchers, doctors, students, movement scientists, physiotherapists, biologists, radiologists, and go on. So we're highlighting here that the Amsterdam Ankle Cartilage team is a joint venture of a multidisciplinary approach. And the team itself, the basis of the team itself was founded by Professor Kerkhoffs, Gino Kerkhoffs, and Sjoerd Stufkens already quite a while ago. And from there we have made a nice evaluation over time and evolution. And now we have this house, and the house that we're living in has a big foundation on the ground with the VU, the universities, and also ACES and AISS, but more importantly also the ACHSS. And because of the pillars that are being built here, we're able to do what we do, growing from only a few members of the team towards a whole big tree. So we think ourselves that we are in the either spring or summer of our research team, but we're still looking forward what the future is going to bring us. As part of the process that's been around for the last couple of years, we were really happy to receive some accreditations, with the most important ones being up in the biggest part of the slide, with the NFU, which is the academic how do you call it? The overall company that supervises all the academic hospitals in the Netherlands, and they gave us an accreditation that in the Netherlands at least we are the expert center for the treatment of cartilage lesions of the ankle and foot. So all over the Netherlands, people come to our place to seek treatment, and this introduces a very nice and high volume of patients that come for us for consultation, and that also really opened up some doors for us. So that's important to mention. But I'm not here to only brag about ourselves, because that's not what you come for. We come here for the scientific session, and already on the basis of the house, I mentioned the different universities and the different organizations that we're affiliated with, but even down into the ground, there are the big pillars, and the big pillars are the science that we build on. And the science that we build on started in, or at least made a bigger evolution in 2018 when we looked back into the radiological database and looked for all the patients with a cartilage lesion of the ankle. And from 2018, we have been prospectively including the patients in this database, and this created a nice big sample size that we can use for questions that arise from the field, from in the consultation room, but also questions from scientists and from patients. And that brings us to the cascade, because the cascade, what Sjoerd was talking about in an earlier phase, is what are we really talking about? Are we talking about the end-stage osteoarthritis all the way at the end of the cascade, or are we talking about only the cartilage cracks that we see, or that we don't see? And for us as doctors, and in which we do a lot of research on nowadays, but we're trying to go up the cascade as well in order to prevent from going down the cascade, is talking about osteochondral lesions. And as Sjoerd mentioned, is that cartilage is aneural and avascular. It's really difficult to regenerate and to have it grown back over time. And that's why our evolution has been to also focus, or mainly focus, on the bone part of the osteochondral lesion. So for the rest, the latter part of the talk will mostly be about osteochondral lesions. So that's the combined cartilage damage and the bone damage underneath, in which we focus mainly in our clinic on the bone part of it. So for this combined lesion, the osteochondral lesion, we have developed a treatment flowchart in which we take into account important patient factors to finally get down into the flowchart and see which treatment option may work the best for which patient. And as part of this flowchart, there's two innovative surgical therapies that I want to highlight shortly that have been developed in the Amsterdam UMC. And the first one is the talar osteoperiostic grafting from the iliac crest. And the indication is something that you can see from the radiological perspective on the CT scan that you can see on the slide, but it's mostly about the patient perspective, because these are patients that have a lot of pain during weight bearing, a lot of pain in daily life, have failed prior conservative therapies such as physiotherapy, injections, and also have failed other smaller surgical interventions such as the bone marrow stimulation that Sjoerd mentioned. And for these larger lesions, these giant lesions, it's important to restock the bone with healthy, viable bone with growth factors from the iliac crest, because in the iliac crest we have this high quality bone stock, which consists of growth cells and of the cambium layer, which in the end can migrate into a cartilage layer into the ankle. So the advantages of this therapy is that, as opposed to the osteochondral plaque that has been taken from the knee, there's no or very little donor site morbidity. So patients rarely complain from pain on the iliac crest. It is you can put it into the ankle joint without any screws or without any fixation therapy. So you don't need any screws for the graft itself. So it's press fit. You can adjust the graft as much as you want, and you can individualize it to the patient's ankle morphology, but also to the dimensions of the lesion that you take out. And this, in that sense, has a number of advantages. We have, concerning the scientific aspect around this, we have published this technique into the medial part, into the lateral part, and these are some images that have been made on the technique, and some radiological results. The upcoming clinical results will come up very soon in the JPGS, and then another surgical intervention that has been developed at the Amsterdam UMC is the lift drill fill and fix, and the lift drill fill and fix was developed by Professor Kerkhoffs, and these patients are a little bit different from a radiological perspective, but also from a demographic perspective than the patients that I mentioned before that are indications for the topic procedure, because these patients are relatively younger. They have this large bony fragment into the ankle joint with a normally healthy cartilage layer on top, which and this type of injury could be there during the adolescent time or the child time when the cartilage needs to grow back into bone, and then this fragment can occur. And patients that do complain of the same complaints of the prior to the topic procedure is that they have deep ankle pain during weight bearing, and then they could be an indication for this fixation procedure. And the fixation procedure is really thinking about it as the hood of a car. The motor that is broken or the engine that is broken inside of the car needs to be fixed, but the cartilage lesion, which is the hood, is stable and is of good quality, so you don't want to take it away, and you just want to repair the engine that's inside. But you don't do that by just washing the hood of the car. You actually want to really open it up and look inside and see what's wrong. And from our perspective, you could see it as follows: cartilage is intact. You want to keep it, so at the end you want to put it back in place and fixate it in a stable position. But then when you look at the bone, it's broken, it's diseased, it's not healthy anymore. So you need to take it away. You need to stimulate it. You need to add a new part of the engine, of new parts of the engine, and you also want to put it back into place so that it doesn't come out and that it's stable. So that's really what this fixation therapy is about. And on the left side, you could see the CT scan, for example, before surgery. Then we lift up the whole fragment to the side. We drill in order to induce to get the biology in there and to let it move up. And then we can add some healthy bone on the basis of the fragment, and which we can take it from either the shin bone or the iliac crest as well, some small bone. And the last part of the procedure is that you fixate it with 2 small screws. And also this one it works effective in 90% of the patients and shows good union. So these are 2 surgical therapies that have been developed over time at our center and that are, I think, important to at least highlight here. But then going back to our house again, because not only these surgical therapies are the basis of our house, we really want to look further and want to do better than what's currently out there. So just a small highlight on the current approach that we are having. And the first one is, are we speaking the same language? It was the first talk in this session as well, is are we naming the same name to some specific indications or some specific patients that we see? So we first need to start with, do we see the same thing in the same thing, or do we see something different in the same thing? So as you can see, there's many different types of osteochondral lesions, or the lesions of the bone and the cartilage, that you can see here with the large fragment on the left side, and then there's a fragment there with a small hole just below it. Then we have another big fragment which is not flying into the joint, which is more stable. Another one with a cyst underneath, but more into the middle part of the joint. Very large cysts, but without a fragment. Yeah, you're already losing me because you don't even know what I'm saying right now, and maybe I don't even know what I'm saying right now, because there's so many different indications and so many different types of lesions that we see. So what we did is we went to our colleagues in the VU from the geology department that have a lot of knowledge about how to name specific natural experiments, and also the types of rocks that are out there all over the world. And because there were some rock formations specifically underneath the ocean, for example, and which is the same thing in the ankle, that the synovial fluid is right there and the bone is underneath, we thought that there might be some similarities in between them. So we are now working together with them to make a specific nomenclature for specific types of lesions that we see. So we're trying to give it a good name. Yeah. Yeah, these are the last slides. Thanks. Then the last ones are prevention of the injury. You don't want to go further down into the cascade, so some people who are here in the crowd are working really hard to not go from the sprain and fracture all the way down into the osteoarthritis. And then we have the AI part as well, trying to build a prognostic model to see which patient really benefits from which procedure. Um, and then the last part, which is very important to finish with, is the patient perspective itself and the mental health perspective, which will be the next talk after this one. What does the patient really need, and what does the patient really think about the treatment and the diagnosis, and how can we answer the questions that the patients come with into our consultation room. And so we're working with a big team on those questions and try to perform also qualitative research on that as well. So the conclusion is work together with a big team to create the perfect homeostasis of your team members, in order to have a multidisciplinary approach to be able to answer all our questions. And last conclusion over there as well is that we welcome all of you to talk with us and participate. So thank you very much for your attention. So I think because we're a little bit over time, we have room for one small question.
Dankjewel. Yeah, my name is Willem van Mechelen. Under the assumption that a sprain actually leads to arthritis in the long run, I mean, that was the first statement up on your slide, then shouldn't you consider to advise to people with a severe lesion to actually quit sporting? Because they are apparently on a sort of a sliding way towards a debilitating state from a functional perspective. And apparently, I get a little bit depressed about the treatment options that you have both sort of presented. So what's your opinion on this?
Thank you for your question. I think the way that it's depicted as well is it's quite a black and white image, but we're still looking to find out which patients do actually go into that cascade and which don't. And for example, specifically, we're seeing patients with nosocoronal lesions that do not get operated on but follow conservative therapy. And we do see over time that the majority of those patients do not go down into the cascade.
Yeah, could it be that there are inter-individual differences in response to treatment as a function of differences in genetic makeup? And then if that would be the case, then would you start doing genetic profiling of these patients also in order to try to find out?
Yeah, that's something that we're also working on or is in the planning, but we first want to find out which patients develop the cartilage damage itself after the sprain. We still don't know that yet.
No.
And for example, we have some examples in the consultation room that there's brothers having the exact same type of osteochondral lesion. So we want to go also into the genetic part in that and find out. But maybe Sjoerd has something to add.
Can the microphone be turn on? Of course, now we've come from an era where looking at the disease has had priority over looking at what the nature heals by itself. So yeah, probably it will be time to start looking at what sprains don't lead to osteoarthritis, but where the body finds a way to heal, and to see if there's in the genome or somewhere else a fingerprint where there's a solution for the patients as well. So I don't think that all sprains lead to osteoarthritis. We don't see that. We see 500,000 sprains each year. They don't all go into osteoarthritis, but some do, and it would be interesting to learn from those who don't what you can do to prevent the ones that do go into the cascade.